This is QD Clinic. Hi, I'm Jack Cush with RheumNow. QD Clinic is brought to you by RheumNow.Live, where we discuss complex problems. There's going to be critical thinking. It all leads to greater confidence in you, the rheumatologist. Be there March 18 and 19. You can register now. Today's case, my bum knee. This is a 60-year-old gentleman who comes to see me a few months ago. He's limping. He's got a bad knee. On first inspection, it looks a little bit enlarged, maybe some bony enlargement. Maybe he's got a little bit of a varus deformity. The story is that this has come on in the last 2 years. It's gotten progressively worse in the last 6 months. So this is a chronic problem. He's got some other aches and pains, a little bit of back pain, little bit of, overuse pains, but he's not very active. He's definitely not in shape. He's morbidly obese. He has high blood pressure and diabetes, takes medicines for that. And he's been taking over-the-counter medicines. Said he once went to the emergency room. They did an x-ray. They gave him a shot in the arm, not in the joint. And he's just been plugging along with the same pains ever since. The question is, what is this? So let's think about this. He's 60. He's got one joint. It's chronic. Obviously, osteoarthritis has got to run right to the top. If not osteoarthritis, what else could this be? Well, without evidence of synovitis and squishy swelling or joint warmth, we're not going to really call this an inflammatory arthropathy. And so something like infection, chronic infection, opportunistic infection would be not really a possibility. And again, there is no inflammation, there is no warmth. He says this has been chronic, which kind of rules out gout. He might be the right age, right sex, but the chronicity kind of rules out monosodium urate as the cause. It doesn't really rule out calcium pyrophosphate. So this could be pseudo-gout. And there's no clear reason as to why he'd have that. What else could this be? And the question is, what are you going to do for the evaluation? Does he need a big laboratory workup? Would I do an ANA and a rheumatoid factor in him? No, I would not. Would I do a CBC and chem profile? Sure. He's got medical problems. He's a bit of a mess when you do a history and a physical. You'd like to know if there's any other issues you're dealing with. There's no prior history of trauma here. Should I get an x-ray? What are the indications for x-ray? First off, x-rays don't usually diagnose these kind of problems. X-rays are really usually done as baseline assessment and to help rule out other possibilities. Could he have a fracture there? He could. Doubtful that it would be there for more than 6 months. But he has the main reason to do an imaging test on him would be A, chronicity, and B, failure to respond to symptomatic therapy. And whether this is a baseline assessment or ruling out other causes other than osteoarthritis, we'll see when we get the x-ray. Anyway, his labs come back. They're all relatively normal. He's got a slight degree of renal insufficiency and a blood sugar that's out of control, a hemoglobin A1C of 9. When you look at the x-ray, he's got, guess what? That's right, avascular necrosis, osteonecrosis, involving the knee. That was a bit of a surprise, but certainly not when we go back to him and say, so why did this happen in you? Do you have a history of trauma? Have you taken steroids? And the answer is no and no, but he does have a problem with chronic alcohol abuse. So that's a significant risk factor for osteonecrosis. Interestingly, men who get osteonecrosis tend to be more in the hip, and women tend to get it more in the knee. What are the causes of osteonecrosis? Well, he had the main one here, that being alcohol abuse, but other causes would include trauma, steroid use, renal failure, transplant, other rheumatic diseases like lupus, rheumatoid arthritis, and such, which often are treated with high-dose steroids, patients with hemoglobinopathies like sickle cell, radiation, pancreatitis, pregnancy, hyperlipidemia, and of course, decompression sickness known as Caisson's disease. So those are the main things. Our guy had osteonecrosis as evidenced by unilateral condylar sclerosis with a bit of a crescent sign and collapse of the condylar surface, so that it was irregular, and this has led to progressive degenerative joint disease. In the short term, it's alleviating pain, really with local measures and crutches. In the long term, he requires a referral to orthopedics and joint replacement. His osteonecrosis has progressed to the point where that's the main thing other than analgesic therapy. Probably no real benefit would be derived, long-term benefit by intra-articular steroids. Intra-articular, lidocaine would only give short-term relief. Intra-articular steroids, again, short-term relief, and probably would hurt the situation rather than help the situation, especially if he's going to have a joint replacement. Anyway, that's the bum knee due to osteonecrosis. Tune in for more QD Clinics. Take care.